Good morning and welcome to UAB Physical Therapy's COVID Corner.
I'm Ashley Parish and I'm an assistant professor in the Department of PT at UAB.
So my name's John Lowman, also in the faculty member in the Department of Physical Therapy at the University of Alabama at Birmingham. Ashley, one of our first questions is, how long after diagnosis is one considered contagious?
So initially it was thought that once you stop showing signs and symptoms of COVID-19, you could be quarantined for 14 days and then be fine. But this really isn't true. So as the U.S. has gained more abilities to test for COVID-19, researchers have really found that people are having the infection for longer periods of time past 14 days. And this is really due to a process called viral shedding, where the body's getting rid of the virus. So China released some really good data showing that asymptomatic kids with COVID-19 actually had the virus in their stool for up to a month after being diagnosed. So we really don't know if, since they still have the virus, if they're still contagious and giving it to other people. In the US, we're seeing that those with comorbidities are also having longer periods of positive testing. So those with diabetes, with heart failure, those who are obese, things like that. So as people are starting to recover from this, we're hearing that it's more like a 6 to 8 week quarantine after you stop showing signs and symptoms of COVID-19, just to ensure that the virus is gone. But this will be updated as people recover and there's more antibody testing.
That certainly helps explain kind of how the line keeps kind of getting kicked down the road. In terms of kind of quarantine, initially 14 days and 30 days and keeps getting a little bit longer. Next question, can patients continue to infect others after they've had a negative test result?
That's a great question. So there's been many instances reported from legitimate sources where somebody's tested negative and had symptoms, and then a few days later that they test positive. So within that window of testing negative to positive, you probably are contagious in giving this to others. And this might be due to how the sample is being taken. So we're seeing patients that are intubated test negative through the nasopharyngeal swab, but they're testing positive through an ET tube aspirate. So we really don't know the accuracy of this testing. So right now, our current guidelines are saying that if you test negative for the virus or to be considered negative, you have to have 2 negative tests within 24 hours of each other.
How we're testing is kind of evolving on a pretty rapid basis. What is the chance that a patient who has been previously diagnosed with COVID-19 to get kind of reinfected?
Yeah, that's the question of the hour right now, especially as we're reopening things in May. We really don't know if people are going to be getting this again. So we're kind of watching Wuhan closely in China to see if they're going to have a high reinfection rate. So right now there is a lot of antibody testing going on in those who had recovered. So it's important to know right now that there are other coronavirus strains out there, and we do have testing related to reinfection rates with those. So with these, after somebody has like a typical strain of coronavirus, we see antibody buildup in the blood. Those people can still get the virus after having it, but it might not be as severe as the first case. So we really don't know with COVID-19 if somebody can get reinfected, if they're going to have a severe course versus asymptomatic the next time they get it. So that is definitely an area of research. Well, John, speaking of spreading the virus, we had a question that was, why is it considered to be a deadly threat?
We've certainly kind of seen the numbers kind of vary. Some people are saying the coronavirus is, no worse than the flu. Some people are saying it's less than the flu. And, all that depends on kind of what numbers go into the numerator and the denominator. What we do know is that this is an extremely contagious virus. Perhaps more contagious than anything else that I've ever heard of. Early on, we always heard that it impacts older adults and those with comorbid conditions, prior health conditions. But now we're seeing, many more kind of younger people in their, 30s and 40s, 50s, without other pre-existing conditions kind of developing it. so the variability just seems extremely wide. So if you kind of, remember back from statistics class, kind of the idea of a bell curve, this is not a really narrow bell curve. This is a really wide bell curve with lots of variability. For those that that have the severe form, the virus is, it's a viral pneumonia. So they're kind of getting like a viral pneumonia that's causing damage to the lungs. And what they end up with is kind of severe hypoxic respiratory failure. So it's, it's not that they're unable to breathe, that their lungs are just really stiff and damaged, but for whatever reason, they're developing this really hypoxic respiratory failure where they can't get oxygen kind of into their blood from their lungs. That kind of hypoxic respiratory failure, if you can't get oxygen into your blood, then you can't get oxygen to the rest of your kind of vital organs. So that kind of sets you up for kind of multiple organ failure. One of the treatments for hypoxic respiratory failure is to be placed on mechanical ventilation. And so early on, they were putting people on mechanical vents kind of early. Now they're trying to kind of delay that. It seems like because one of the complications of mechanical ventilation is what's called barotrauma, or just kind of pressure trauma. So the ventilator, positive pressure ventilator, can kind of overdistend the lungs and kind of damage the alveoli. As that happens, then the virus, now it's easier for the virus to get out of the lungs and into the bloodstream, and kind of spread to other areas, and for sepsis to develop. So there can be kind of this issue. And so it's not necessarily the virus itself initially, but sometimes the medical treatment for mechanical ventilation that can cause trouble. One of the other things that, and so patients are developing what we call, what's typically called acute or adult respiratory distress syndrome, or ARDS, ARDS. And the ARDS that folks are developing with COVID-19 seems a little bit different than kind of traditional ARDS. And it almost looks like they're developing kind of a pulmonary edema similar to what you would get at altitude. So kind of mountaineers that kind of climb in the Himalayas, that go up at high altitudes, they develop what's called high altitude pulmonary edema. And that seems to be one of the issues with this virus, is that they're developing pulmonary edema similar to what happens at altitude. And the way you treat that typically is, reduce the altitude, come back down to base camp, and oxygen. And so oxygen is kind of the treatment. The best mechanism for this, for providing this excess oxygen, is kind of yet to be determined. There's kind of high flow nasal cannula. Folks are on masks, non-invasive ventilation, and again, some patients are intubated and put on the ventilator. And again, those folks that are on the ventilator, can end up having long-term sequelae, both from the mechanical ventilation, as well as kind of as the lungs recover from this COVID-19. One of the things that the lungs do to recover and heal themselves after they've been damaged is scarring. So they develop kind of scar tissue. So for the survivors of COVID-19, we're really not sure, how their lungs are going to heal and what kind of long-term consequences from a pulmonary infection or from a pulmonary standpoint that they're going to have in the long run. But there's likely to be some chronic effects on the lungs.
Yeah, and I bet there's going to be some great research in the upcoming years about following patients after these episodes of ARDS from COVID-19. All right, John. Well, our next question is kind of an intervention type question. So our question is use of incentive spirometry effective in this population?
That's a good question. Some people have kind of minimized the impact of incentive spirometry over the years. I think if done properly, incentive spirometry has a lot of benefits. In particular, in prevention, kind of prevention of pulmonary issues, prevention, kind of keeping the airways open. So the purpose of an incentive spirometer is to give you an incentive to take a deep breath, really. So it's just really a kind of a method of biofeedback. So, you've probably kind of all seen an incentive spirometer before. Here's one. Most incentive spirometers have two components. One, over here on the side, kind of newer incentive spirometers give you a little smiley face or a frowny face. So if you go too fast, you get a frowny face. If you go too slow, you get a frowny face. And then if if you're like Goldilocks and you're right there in the middle, then everything's just right. The second thing on the incentive spirometer is what most people pay attention to, which is the height, how high you're going up on the incentive spirometer. Again, the purpose of the incentive spirometer is to give a patient an incentive to take a deep breath. And deep breathing is probably important here. As you kind of breathe in, you're taking in oxygen, you're kind of keeping the lungs open. If we can keep the lungs open in patients that have COVID-19, perhaps we can prevent kind of a secondary bacterial infection. So the last thing they need is kind of a virus like COVID-19. And on top of that, get bacterial pneumonia. So we want to kind of keep the lungs open, healthy. And incentive spirometry is one way to do that. In particular, if patients have been in the bed for a while and may have some collapsed areas of the lung, or what we call atelectasis, then we want to reopen those up. And the best way to do that is to kind of take a deep breath in and hold it. So patients shouldn't use the incentive spirometer fast and then let it go. So they should kind of use it slowly, not too slow, but just right here in the happy face. Some people are just kind of motor morons, and you've tried to teach people a quad set and they don't know how to do a quad set. If they can't do a quad set, then teaching somebody how to use an incentive spirometer is even more challenging. So I would venture to say 25% of the patients that I've tried to show incentive spirometry can't quite figure it out appropriately. In that case, I just ask patients can you take a deep breath in and hold it for me? Everybody can do that. So again, the incentive spirometer is just a biofeedback device. It's supposed to be an incentive, not a disincentive. So, if your patients are getting frustrated with an incentive spirometer, then just set it to the side and tell them, hey, when you see your incentive spirometer, I want you to take 4 or 5 good deep breaths in and hold it. Because it shouldn't be frustrating. It should be something kind of encouraging. It may not help specifically treat or get rid of COVID-19 or the symptoms, but it's certainly going to be kind of effective. Kind of the risk benefits, there's no risk to it. And the benefits and kind of preventing kind of atelectasis and preventing kind of further pneumonia is going to be important.
Great. So our last question is kind of a hot topic. So the whole idea of aerosolized activity and if we should do it or if we shouldn't, it's been debated heavily amongst practitioners. So our last question is, are breathing techniques considered an aerosolized activity?
Yes, you're exactly right. This has been kind of a hotly debated topic. As I mentioned earlier, earlier on, they were putting folks kind of directly onto the ventilator and avoiding some kind of non-invasive techniques because they were worried about kind of aerosolizing the virus with things like high flow nasal cannula. And certainly that is a concern. Breathing is a kind of an aerosolized activity. I mean, if anybody that's ever, been outside in cool weather and breathed out, well, you see your steam, your vapor kind of leaving your lungs. So those are aerosolized particles, kind of leaving your lungs that we typically don't see. But so yes, breathing does kind of aerosolize things. How much does it is kind of the question, and how far does it go is a great question. And that's really kind of the idea behind kind of wearing masks, is that the things that are aerosolized by other patients, other people in the community or in the hospital, that it prevents you from breathing it in. But also, if you're a carrier, if the patient actually has COVID-19, them wearing a mask, it prevents them from aerosolizing. This certainly isn't breathing techniques, breathing exercises. It's not something we want patients with COVID-19 to be doing, in the hallway, out in public, but certainly in their own room with the door closed. A lot of these, patients that are positive for COVID-19 are placed in a kind of a negative pressure room. then yeah, doing deep breathing exercises like we just discussed with incentive spirometry or deep breathing are going to be important for them to try to kind of keep their lungs healthy, to get the oxygen in. Yeah, they should be kind of doing breathing techniques. Now, if you're the therapist, you know, you obviously want to have some kind of barrier between you and the patient as they're doing these techniques. One of my favorite techniques, other than deep breathing, which is focused more on inspiration, is what we call huffing. Some people call it the forced expiratory technique, which is it's kind of similar to a cough. Some people call it a huff cough. I don't like to call it that because I want to separate huffing and coughing as two separate activities. But it's really kind of a forced expiration without closing your glottis. So in a cough, you kind of close your glottis, you develop a lot of pressure, and then you let it loose. With huffing, you don't close your glottis. So you just kind of take a deep breath in and exhale rapidly without ever kind of closing your glottis. So the key thing there is kind of keeping your mouth open. Now we can do this kind of safely here because we're socially distanced, right? But the last thing you want somebody to do would be huffing on you. I mean, this is going to, you know, aerosolize particles and send them out. You know, so, you know, that's why we cough into our elbow. That's why we wear kind of a face shield with our patients when we do airway clearance. So those techniques are going to be useful to teach patients how to do. But certainly while we're protecting ourselves with personal protective equipment, and encouraging them to kind of do these activities kind of independently on their own. So, you know, yes, we can kind of teach breathing techniques, especially things like the forced expiratory technique or huffing, like I just described, would certainly kind of be considered kind of an aerosolized activity. But we need to kind of put a barrier between kind of the patient and others to kind of minimize the spread of that. But huffing can be extremely effective in people that have secretions. So you know, I don't teach this to anybody, but people that do have secretions that need to be cleared, huffing can be a great way of getting rid of those kind of excess secretions.
Absolutely. So thank you guys for tuning in to our first episode of COVID Corner. We did have several other questions that came in that we are going to field on a future episode. So in the meantime, if you think of anything, any questions for us, please go to our website at uab.edu/pt and submit them, and we will answer them soon. Thank you guys.
Yes, and thank you, Ashley.